Well, it's very interesting. A public health man in the midst of clinicians, and especially tiny clinicians. Sorry for that. Maybe a pediatric clinicians. Uh, it was a challenging for me to when Dr. Muthu gave me a topic to speak on the public health aspects of ECC. Uh, Challenge in the sense is that uh, how, since it's this public health approaches in periodontal disease, we worked a lot on that, how to approach the disease preventions at the community at a mass level for periodontal disease. And I did my work also in the ECC during my fellowships in the US. Uh, I was trying to understand that, like, the perspectives of how a disease can impact public health, and how does it, reflects upon the all the stakeholders for that particular event or issue, to look at the issue to solve it. Most of you, the visions of, especially in a public health approach, we look at uh, a mass strategy and a high risk strategy. So most of what I heard now, or what you were seeing, is about high risk approach, where people with ECC, what we can do, or how we can do it, how we can prevent it. But looking at whole population approach is most important, because that's where the uh, you know those people who are at risk of getting an ECC to be prevented. That is population at risk. So what I'm trying to do here is to give you a very brief perspectives about how a tiny teeth is impacting the public health, and it is getting unnoticed. So, and I would say it is more of a silent epidemic. So I guess, went through some of these sources and found out, in treating ECCs, we have a lot of issues, and we have some catastrophic events, like when the pediatric dentist was treating ECC, the patient collapsed for whatever reasons, and there are a lot of cases like this in the media, may it be negligent, non-negligent, it's a different. But what I'm trying to highlight a point here is, this is a very young age, and where the patient has to go for a therapy which is difficult to manage at the routine settings, and it has to be operatory there, and then and what are the consequences of that. And you can see one of this, even if this is one of the reports like this, where the patient died on the chair, or patient died on the operating room because of the anesthesia or whatever is there. So it shows that how important the problem is, and this is very important for a policy perspectives, because these incidents reflects that how the system works for a care. So early childhood caries, I know that everybody are have true understandings of that, but I'm trying to give you a different word called syndemics here, because it's not syndemics is an interaction between the different factors, especially the biological factors and the social factors, and this two interaction will result in the diseases. And this is this forms of ECC is a good example for that, where you have a biological factors, those factors, but still the social factors, the cultural factors, the family factors, the political, legal, so many things are involved in this, in the formation or in pathogenesis of ECC. Now, for the lack of time, I could have explained in detail, but still trying to give you a brief, outline that ECC is not looking at only at one particular biological agent as such, but it is so many factors which includes because so many stakeholders are there in the progression of this particular disease. So now, what is important for me to understand, make you to understand, is it a public health problem? So, what is the criteria do we say for a public health problem? The difference between a population desired and actual status is substantial. Then we say the public health problem. Now, next we talk about the burden in terms of morbidity, mortality, disparity, and economic burden. Now, we use a criteria called preventability from the collective action. Can we prevent a disease? If we cannot prevent a disease, then we say that, okay, it is not a public health problem because we can't do anything. It is just going on. The next one is perception. See, we also have a lot of numbers. If you go to oral diseases, oral health status report of WHO to 2022, there are numbers which is mind-blowing numbers for oral diseases, dental caries, periodontal disease, tooth mortality, edentism. But does this number makes a difference? No. Actually, unless there is a perception from the different stakeholders that it is a problem, we should work on it. Unless that perception criteria comes in, problem, whatever issue doesn't become a problem. So let's see whether apply these four concepts. There are other concepts, criteria are there, but let us apply this and see whether ECC fits into this as a public health problem. So the burden, we have numbers like every second child globally is affected by ECC. Okay, if you look at that systematic review, a lot of papers are there. So there is a disparity in the prevalence between the continents. You can say 30% to Africa, 48 to Americas, Asia 52, Europe 43%, Oceania 52. Now there is a disparity also. So this disparity, it shows that even people, the children in underdeveloped or second world countries have lesser compared to others. But again, when you go within the region, there is a disparity within the region. So this is, one is the number is more, every second child has it now, and also there is a disparity between it, and almost in Oceania, if you think it is almost 80%. Everybody has it. Now this gives you as fits into criteria of a public health problem because it satisfies the number. Okay. Now when you look at consequences is has social, psychological, economic impacts on individual, community, and health services. So and it reflects the poor oral health. So it is also gives you a criteria to fit into that. Okay, it is a problem. Mm-hmm. Now, number shows the problem doesn't matter. Like what we have is from different studies. People, primary children who are affected with primary tears, DCCs. These numbers are. And these numbers vary according to different years of age. So like 1 year, second year, third year, and as the age increases up to 6 years, you can find that there is increased trend of prevalence of ECC. And this number, anybody, if you take it to a policymaker, should believe that or say, oh, this is the problem and we should work on these issues. But does it, again, number alone makes the difference to be a public health problem. So even if you look at those countries and around the world map, global prevalence, it varies and there is a disparity there. Now, what is the impact of ECC? Impact of ECC locally, the orofacial dysfunction, that includes quality of life, parents' distress function, family functions, child self-image, and psychological status. Now, It can affect the systemic health, but if you have noted here the malnutrition and milestone development infection and so many other diseases. So impact is also very high. Now perception, the healthcare providers, the dentists, pediatricians, pediatric dentists, other healthcare providers, what do they perceive ECC? Now, what the child and the parent perceive is about the ECC. Does it a problem which affects them? Does it a problem which they should take care of it? Is it a problem where it should be taken care of, or how? And should I invest or should I devote, or how do I do this? And is it worthwhile doing it? So these perceptions, if you take, even by the healthcare systems, because when you look at the many healthcare systems around the world, the problems are big. I'll give an example of COVID-19. COVID-19, the perception was so high, they wanted it to be considered as a global public health problem. And when they consider global public health problem, then the fund flows, then everything stops for combating that particular health issue. But if you look at COVID-19, and they developed the vaccine in 17 months, normal vaccine development takes around 20 years in time. Imagine it can be. So what I'm trying to say is that unless there is a perception among the people, providers, and the healthcare systems stakeholders that this is a problem, they won't consider it, won't become as a public health issue. Now that is why we may be we are passionate for our own subject or area of working, but that passionate has to be reflected, in the terms of perceptions among the different people there. So that's why the public health problems remains the whole, because perceptions are very less. Even though the numbers are there, all the impact is there, but still the perception is very low. Even if you look at the economic burden, the difference in how they access the care for economic reason is around, tenfold difference is there, and 1,000% difference is there between the communities. People all cannot afford the restorative or surgical care of ECC in case of severe ECC, or even for a regular ECC restorative treatment also. The differential approach is there, because so many issues of availability, accessibility, and affordability of the care for those population. And caring is also giving care to those people is also a difficult job. So that's why there is a huge economic burden, and it is also differential. And the most of the, if you look at other countries, the cost of care is very high. There was a report in Ministry of Family Welfare in 7 years ago. They, estimated around $5,000 crores are required to treat dental caries in India at the age of 12 years. It's for a permanent treatment. Imagine it's for 12 years to, if you're having a 3 DMFT, it takes around treatment of around, cost is around $5,000. So imagine it is only for restorative, pulpally involved teeth. But you imagine in the case of ECC, what would be the cost of that? And that $5,000 is 5,000 crores is equivalent to a child's health budget. So that's why the perception, the priorities for the stakeholders comes less, because there are bigger problems which causes more impact. But that's why they try to weigh like that and try to put it down, but still it affects. This is a huge cost involved in the treatment of the ECC. So individual curative care, if you look, patient requires a highly skilled dentist, clinician, and patient compliance to maintain dental health, and there comes a problem. So this also has an impact, because people don't, lot of efforts are needed to for the get the care and also to maintain those care. So philosophy, if you look at that, models of biological behavior model focusing on controlling the biofilms, especially the dental plaque, reducing repetitive bacterial load, eliminating high risk behaviors, and biomedical organisms can be done, but can maintain, but secure and maintain it, but still it is not for everybody. It is so difficult to, for me as a public health professional, to look at how can I do these things for whole population in India or any other situation. So high risk for disease progression should be focused only, if it should not be focused, should be focused only for the therapeutic interventions for a small group of people who needs care. But we have to worry about where we are not putting those population at risk into high risk categories, so that we need some approach where we have to have a public health approach to prevent the emergence of high risk groups from the PAR. So traditional approach, clinical approach, has limited ability to make changes in the ECC prevalence at the community level, because this the window time of progression of a disease is 6 years, and you have to work very fast, and that time is so difficult because there are a lot of people are involved in the particular care of the child, and so it's the approach is very difficult. So looking at the preventability is what traditionally we use this type of approaches, like promoting oral hygiene, toothbrushing, flossing, mouth rinsing, or recognizing the individual factors like enamel defects. Population-based strategies for preventing are through an integrated approach rather than a siloed approach is more important. It can be done. And community-based techniques for fluoride use and multi-pronged strategies during prenatal, postnatal, integrated Medicaid care, and social monitoring policies can be borrowed from the other instances and then added to the ECC component. Now, problem with that, everybody works in a piecemeal basis, and I look at periodontal person, we look at periodontal disease as one thing, and dental caries permanent to ECC. We are not looking this at the disease as at a continuum process where the plaque is a factor for everything. And we look at plaque strategies, biofilm reduction strategies at the where at the primordial or primordial levels. Then this having an horizontal approach to the process would be more better than looking at a siloed approach where at the vertical approach. So anyway, what I'm trying to say is that these type of strategies are available, which can be incorporated into the ECC, and when we start with the ECC, that strategy will continue for other diseases also, other oral diseases or other plaque-related diseases. So risk factors for ECC, we have a lot of risk factors, and I think there's a very nice systematic review which gives you a comprehensive list of risk factors, and it gives you a strength of those risk factors for the causation of ECC there. But the question here is, what I was trying to bring out, a concept here is allostasis in ECC is a adapt. The problem with this risk factors approach is that we look the disease into agent plus host is equal to disease, and we are looking each of these risk factors at one axis, but there are multiple axes are there in one particular person which causes the disease there. So when we look into those three-dimensional or multi-dimensional views and different axes for each of the risk factors, and there is a interaction between these risk factors there, and that is very important for progression causation of the disease there. So that understanding is very important for every disease, but this is important for ECC because there are a lot of processes are involved. Like what one paper was trying to describe is about heliostasis in ECC, where uh, adaptive process, a body changes the levels of one or more regulated parameters to adjust the new environment. Now, what it means is, now there are different stresses are there. Okay, life stress, biological stresses, genetic familial predispositions, social stresses, behavior stresses, family and culture. All these things are occurring at the stage of very small window period of 0 to 6 years. Now, these will interact in a complex webs and causes the ECC. Now, uh, how does it cause? It's a conceptual one, but still, it makes an relevance to understand that it's not so easy that if I reduce the bacterial load, others will. There are so many other things will come into picture in doing this, because there are behavior social stresses are more important, which causes this. Now, when we look at the public health approach, what I'm trying to understand, make you understand, is when you look at these causations, we look at how can I look at cut off those factors to look at in a preventing at a community level. So these things and all can be not be managed at the individual level also easily, but it's difficult to manage at the community. Now, the best approaches is to make sure that whether my public health approaches is able to convert, make sure that these loads are reduced in the particular dyads or mother or in the family ecosystem of the family, where there is a stress, there is a risk of ECC. So whether I can able to reduce those, if the strategies can reduce the stresses, then the ECC at the community level will come strong. Otherwise, it's so difficult. You can see that it is a universal that everybody has an issue in every country, every culture, or every continent, regardless of the any ethnicity or race differences. So ECC to the medical example, what I'm trying to give you and how it is linking to the systemic health. An example with the malnutrition, which we did a study to find out how ECC is linked to the malnutrition, and how one child has a ECC, then what is the level of malnutrition they can have. And when we look at the causal group model of factors affecting the interaction, it's so complex web. It's so complex web, and we are if we it is we thought that ECC is more common or people with higher economic. Now we don't see that difference. Now it is more common again the people with the lower economic status. So there are so many schools of thoughts suggesting many other reasons for that, but still it's so complex that it can affect the affects the medical health issues of the child, and imagine that in the nutritional programs, especially in those policies including the child nutrition. In India, child nutrition having a problem of even the policies of having for the reduction in child malnutrition. You can see that 40% of children still undernourished and have some problems. So, can we able to give a link or evidence to say that we have evidence, but have this evidence has been translated into a way with the evidence users, that policymakers understand that this is one of the important things that we should look onto, that to see whether this care of malnutrition, ACC is included under the malnutrition program. Now, these window opportunities or entry points have not been, the research has not been there, and we are not able to demonstrate those things at the community level, because we may do it at the individual level, at the group level, but community level, and it can be taken up by the communities. So translation strategies are important. What we are looking at strategies is that imagine a child here, 3-year-old child goes to a clinic and he has a lot of caries and it can't be done by routine facility. It has to go for a under general anesthesia or conscious sedation. But are we bringing out those strategies in the community where this issue of medical developmental psychological sequelae of this ECC can be stopped, and that's where we have to look at the public health approaches, and that is where it impacts the public health. So there are initiatives and concepts which you could see in the literature about the public health intervention for ECC. I think the results, the WHO had brought up some consultations, and there are SDGs incorporating of ECC care and the SDG development goals. I see. Yes, absolutely. These things are very nice, and I think the conceptual model is very good. But the question here is, there are very few demonstrative models are available for people to take up this and to adopt it in the community. That's where we are able to lack in that. Knowledge to action gaps lacking here in the, especially the public health action. So way forward for a public health approach is what I would envision based on my experience and the literature available. Recognition that it is a public health issue, and that has to be adopted by the people there, especially by the by the person who's high-risk person, the mother, child, and the caregivers, care providers, and the stakeholders. Interprofessional collaboration strategy. That's what all the conceptual models have brought up, that we can't work alone. It has to be medical dental integration models. We can work on the ECC there. And the next one is those things which can be a translation, looking at health promotion, oral health promotion using the Ottawa chapter, which includes a social engineering model. Not I'm looking at one biomedical model where we translate. We don't get much thing there because we don't get it is not for everybody. So early childhood caries one settings can be catastrophic for the child, caregivers, healthcare providers, and society at large. If we cannot provide a good care for a child, especially a tiny teeth which is having a reduction of dental caries, I think we should. It's because people fall on small stones rather than large stones. COVID was a large stone. We could able to, get through it, but not the ECC because it's the smallest. And that's why doing the smallest thing is the biggest issue. So I would suggest that ECC is a wicked problem, because more than a public health problem is a wicked problem, because wicked problem is having a social, cultural, institutional issues, healthcare issues, systems issues, which is difficult to solve. But it has a large public health issue because it is a wicked problem. So this is what I was trying to explain, that how impactful is the tiny cavities, and how important for us to look at ECC the public health perspectives and try to work with the healthcare systems, how we can incorporate ECC in the prevention and public health approaches. Thank you for patient hearing.